Imagine a common ailment affecting up to, well, 80% of us in our lifetime.
That's a staggering figure.
It really is, and it's a condition costing the healthcare system billions each year, yet the vast majority of cases, interestingly, often resolve without ever needing surgery.
Hmm.
So as medical professionals, how do we truly grasp and effectively navigate the complexities of this pervasive condition? How do we ensure the best outcomes for our patients?
That's the central question, isn't it?
Welcome to the deep dive. We take critical information and distill it into actionable insights for you. Today, we're plunging into the often misunderstood world of herniated discs, a primary culprit behind that debilitating back and leg pain we see so often. I'm your host, and I'm genuinely thrilled to be joined today by a distinguished authority in orthopedics.
It's a pleasure to be here.
He brings decades of clinical experience and a profound academic understanding to the nuances of spinal health. His insights into everything from conservative management to pioneering surgical techniques are really invaluable for any professional looking to deepen their expertise in this field.
Well, thank you. I hope I can shed some light.
Together, we're going to unpack what a herniated disc truly is, its far-reaching implications, and the cutting-edge approaches to managing it effectively. This isn't just about reciting facts, it's about translating knowledge into clinical excellence for you. So, to kick us off and really set the stage, let's dive straight into a rapid-fire session. First, in your experience, what's the single most common misconception medical professionals, or perhaps even our patients, tend to hold about a herniated disc?
That's a brilliant place to start. I think the most pervasive misconception is that a herniated disc inherently demands immediate surgery.
Right, that it's an automatic surgical case.
Exactly. Or that it signifies some kind of permanent, irreversible structural failure. The core insight here, which we often have to reinforce, is that approximately 85 to 90% of symptomatic lumbar disc herniations will resolve spontaneously.
Spontaneously, without intervention.
Yes, with conservative treatment,
Yeah.
usually within a few weeks to a few months. It's a natural healing process that's often underestimated.
That's crucial.
Furthermore, and this is key, imaging findings don't always correlate with clinical symptoms. We frequently see disc herniations on scans in entirely asymptomatic individuals.
So an MRI finding alone isn't a diagnosis.
Precisely. It has to fit the clinical picture.
That distinction between imaging and clinical reality is absolutely vital. Following on from that, what's the most crucial red flag symptom? The one that should immediately trigger alarm bells and demand urgent attention when you're evaluating suspected disc issues.
Without a shadow of a doubt, it's the sudden onset of bilateral leg pain and weakness.
Both legs at once.
Yes, accompanied by saddle anesthesia, that's a loss of sensation in the genital or rectal region, and, critically, any new onset loss of bladder or bowel control.
Okay, that's the absolute must not miss.
Absolutely. This constellation of symptoms strongly points towards cauda equina syndrome. It's rare, but it's a severe compression of the spinal nerve roots.
And that demands urgent surgical intervention.
Urgent, ideally within 24 to 48 hours, to prevent permanent neurological deficits. Time is nerve in these cases, quite literally.
That's a critical clinical reminder for all of us. Finally, considering the significant economic burden that back pain places on healthcare systems globally, how has our contemporary understanding of disc degeneration evolved to influence our early intervention strategies?
Well, our understanding has really matured. We've moved from seeing it as a purely mechanical issue, just disc compression, to recognizing the profound role of inflammatory mediators, things like TNF-alpha, which are released by the extruded disc material itself.
So it's not just pressure, it's inflammation too.
Exactly. And this shift has fundamentally reinforced the emphasis on initial conservative management. We now prioritize anti-inflammatory medications and highly targeted physical therapy as the first-line treatments. Often, they're the most effective interventions.
Leveraging the body's own processes.
Precisely. The goal is to leverage the body's remarkable natural healing capacity and those high rates of spontaneous resolution we talked about. This approach not only optimizes patient outcomes, but also significantly reduces the need for and the associated costs of unnecessary invasive procedures. It's about working with the body's inherent ability to recover wherever possible.
You've just laid out the prevalence, the economic impact, and some crucial high-level insights. Now, to truly appreciate how a disc can go wrong, we need to understand the marvel it is when it's working right. Can you walk us through the fundamental building blocks of the spine, particularly focusing on that critical lower back region?
Absolutely. The human spine is truly a remarkable piece of biological engineering. At its foundation, it's composed of 24 individual bones, which we call vertebrae.
Stacked one on top of the other.
Meticulously stacked, yes. In the lower back specifically, we find 5 of these vertebrae, designated L1 through L5, forming the lumbar spine.
And that has that characteristic inward curve.
It does. The natural inward curve, or lordosis. It provides crucial stability and support for distributing the upper body's weight. These vertebrae articulate, they connect, to create a robust yet flexible canal. And that protects the delicate spinal cord and the branching nerves as they exit. Nestled precisely between these vertebrae are the intervertebral discs.
The shock absorbers.
Exactly. They're flat, round structures, typically about ½ an inch, maybe 1.25 centimeters thick. Their primary, indeed vital function is to act as sophisticated shock absorbers, cushioning the vertebral bones from the forces we exert during daily activities, walking, bending, lifting. Now, when we delve deeper into the discs themselves, they're fascinating structures, sort of biphasic. They comprise 2 primary components, each with a distinct role.
Okay.
The outer layer is the annulus fibrosus. You can think of it as a tough, flexible, multi-layered ring.
Like the layers of an onion.
Very much like that. It's meticulously structured from 15 to 25 concentric sheets, or lamellae. These are primarily composed of type I collagen, known for its impressive tensile strength, and a network of proteoglycans.
So it's strong but flexible.
Precisely. This intricate architecture grants the annulus its remarkable extensibility and incredible tensile strength. It allows it to effectively contain the inner nucleus and also to withstand and dissipate the significant twisting and bending forces the spine experiences during movement. It's absolutely crucial for the structural integrity of the disc. The second, and equally vital component, is the nucleus pulposus.
The jelly in the donut.
That's the classic analogy, yes. It's the soft, gel-like center. Its defining characteristic is its high water content, comprising approximately 88% water in healthy young adults.
88%. That's mostly water.
It is. Its remaining composition includes type 2 collagen, which provides a more flexible scaffold than type I, and a high concentration of specific proteoglycans, notably aggrecan and versican.
And they're important for?
Aggrecan is pivotal here. It's highly hydrophilic, meaning it loves water. It has an exceptional ability to bind and retain vast amounts of water.
Ah, so that's what gives it the compressibility?
Exactly. That's what allows the nucleus to effectively absorb and distribute axial loads, the downward pressure. Versican, in turn, binds to hyaluronic acid, contributing to the overall matrix structure. This highly hydrated matrix provides the disc's compressibility, its shock absorption capacity, and fundamentally its role in maintaining the height between the vertebrae.
And keeping the space for the nerves.
Correct. A critical anatomical point for our audience, for you, is that the intervertebral disc is largely an avascular structure, especially in adults.
No direct blood supply.
Right. It primarily relies on diffusion of nutrients from the cartilaginous end plates of the adjacent vertebrae to sustain its health and metabolic function.
Which also means?
It means it has a limited intrinsic healing capacity, especially when it gets damaged. That avascularity is a key factor.
That jelly donut analogy really works for visualizing its function. So, if the annulus fibrosus is built for tensile strength and the nucleus pulposus for shock absorption, what actually happens when this ingenious system falters? How does a disc herniation truly occur? What are the specific biomechanical failures involved?
Well, when we speak of a disc going wrong, we are fundamentally referring to a herniated disc. This is a clinical term that encompasses various manifestations, sometimes called a bulged, slipped, or ruptured disc.
Different names, same basic problem.
Essentially, yes. At its core, it signifies that a fragment of the disc nucleus, that central jelly-like material, has been pushed out of its normal confines within the annulus fibrosus.
Through a tear in the outer ring.
Exactly. It extrudes into the spinal canal through a tear or rupture in that tough outer annular layer. The underlying pathophysiology, how it happens, can typically be understood through 2 primary pathways, though sometimes they overlap. The most common scenario involves disc degeneration.
Which is often age-related.
Predominantly an age-related process, yes. It often starts subtly in our 20s and 30s, although the clinical symptoms tend to peak later. As individuals age, the cells within the disc, the fibrochondrocytes, undergo cellular senescence.
They get old and less functional.
Essentially, yes. This leads to a marked reduction of the production of crucial proteoglycans, especially that water-binding aggrecan. With fewer proteoglycans, the nucleus pulposus loses its ability to retain water effectively.
So the disc dehydrates.
It dehydrates, and consequently loses height. It collapses somewhat. This desiccation and loss of height significantly increases the mechanical strain and stress on the surrounding annulus fibrosus.
Making it more vulnerable.
Exactly. It predisposes the annulus to developing microscopic tears and radial fissures. These structural weaknesses then provide a pathway, an exit route, for the nucleus pulposus to herniate, often triggered by repetitive microtrauma or a specific event.
So the disc is usually already weakened before it herniates.
That's a critical clinical point. Discs that ultimately herniate are, in nearly all cases, already in an early or moderate stage of degeneration. They don't typically herniate from a perfectly pristine, healthy state. The second pathway involves acute injuries.
Like a sudden trauma.
Yes. Significant axial overloading, perhaps from a fall, or crucially improper and forceful lifting, can apply large, sudden biomechanical forces on a disc, even a relatively healthy one. This can lead to an immediate, acute failure or tear in the annulus, causing an instantaneous extrusion of disc material.
So it can be gradual wear and tear or a sudden event.
Correct. Regardless of the mechanism, the consequence is the same. The spinal canal has very limited space. This displacement of disc material, even a small fragment, can directly compress nearby spinal nerves.
Causing pain.
Or, equally importantly, it can chemically irritate them. The nucleus pulposus contains substances that the body often perceives as foreign when they escape the disc, triggering an inflammatory response.
Ah, the inflammation again.
Yes, and that inflammation can be a significant pain generator in itself, leading to pain ranging from a dull ache to that excruciating, sharp, electric shock-like sensation we hear about.
And why is it usually posterolateral? Towards the back and side.
That's down to anatomy. For lumbar disc herniations, which account for 90 to 95% of cases, the posterolateral aspect of the annulus fibrosus is inherently thinner.
A weak spot.
A relative weak spot, yes. And it lacks the robust reinforcing support provided by the posterior longitudinal ligament, which runs down the back of the vertebral bodies. This makes it the most common site for herniations, directing the disc material towards the exiting nerve roots in the neuroforamen. Several factors significantly contribute to the risk of developing a herniated disc. Understanding these is crucial for patient education and prevention.
What are the key risk factors we should be aware of?
Age is paramount. As individuals get older, the water content in their discs naturally decreases, making them less flexible, less resilient, and thus more prone to herniation. The peak incidence is typically in the 4th and 5th decades.
40s and 50s.
Yes. Improper lifting techniques are huge, especially using back muscles instead of leg muscles, and twisting the torso while lifting. That dramatically increases vulnerability.
Using your back like a crane.
Precisely. Being overweight or obese, particularly a BMI over 30, puts added chronic stress on the lumbar discs, accelerating degenerative changes.
Occupations involving repetitive movements.
Definitely. Constant lifting, pulling, bending, or twisting. Think construction workers, nurses, delivery drivers are strongly associated with elevated risk due to cumulative microtrauma.
What about driving?
Frequent driving, especially for long periods, combines prolonged sitting with constant engine vibration, which can place sustained, low-grade pressure and shear forces on the discs.
And a sedentary lifestyle.
Yes, a lack of regular core strengthening exercise weakens the supporting musculature of the spine, leaving it more vulnerable.
Smoking, too, I believe.
Smoking is a recognized and modifiable risk factor. It's thought to compromise the oxygen and nutrient supply to the disc via those end plates we mentioned, thereby accelerating degeneration and impeding repair.
And finally, genetics.
There's a recognized genetic predisposition. Research suggests a family history of disc problems can increase an individual's susceptibility, implying some hereditary component to disc integrity and how prone it is to degeneration.
That comprehensive overview of the mechanics and risk factors really frames the problem. But here's where it gets really interesting for us clinicians. How does this mechanical displacement and maybe the inflammation actually translate into the incredibly varied and often debilitating symptoms patients experience? And specifically, can you delineate how a straightforward disc herniation can lead to that classic picture of sciatica or differentiate into distinct radiculopathies?
That's the clinical crux, isn't it? The way a patient experiences symptoms varies immensely. It primarily depends on the exact position, the size of the herniation, and crucially, whether it's directly impinging upon or chemically irritating a nerve root.
So it's all about location, location, location.
Very much so. It's a fascinating diagnostic challenge because if the disc material isn't directly pressing on a nerve, or if the inflammation is minimal, a patient might just experience a diffuse low backache.
Or even no pain at all.
Or even no pain at all. This is why those imaging findings in asymptomatic individuals can be so misleading if you don't correlate them clinically. However, if a nerve is compressed or chemically irritated, then pain, numbness, or weakness will manifest quite precisely.
In the area that nerve supplies.
Exactly, in the specific dermatomal and myotomal distribution supplied by that particular nerve.
Mm.
Let's break down the typical presentation, starting with the most common, the lumbar spine.
Okay.
A frequent and often profoundly debilitating symptom is sciatica, which clinically we call lumbar radiculopathy.
The nerve root pain.
Correct.
Yeah.
This frequently results from disc herniation in the lower back, typically at the L4, L5, or L5S1 levels.
Mm.
Sciatica is characterized by pain often described as burning, sharp, or like an electric shock accompanied by tingling and numbness.
Radiating down the leg.
Yes, radiating from the buttock down into the leg, and sometimes even into the foot. It almost always affects only one side, left or right, although very large central herniations can cause bilateral symptoms.
What makes it worse?
Patients often report the pain intensifying with activities that increase intraspinal pressure, things like standing, walking, prolonged sitting, coughing, or sneezing.
And the straight leg raise test.
A classic clinical finding. Straightening the affected leg, as in the SLR test, can significantly worsen the pain, reproducing that radicular symptom down the leg. For acute sciatica, it's a notable observation that the leg pain is often reported as being far more severe and disabling than the low back pain itself. That helps differentiate it from simple mechanical low back pain.
Can we get more specific about which nerve root causes which symptoms? That's vital for diagnosis.
Absolutely. Correlating symptoms to the exact nerve root is essential for precise diagnosis and, if needed, surgical planning.
Let's take L3, for example.
Okay, for an L3 radiculopathy, you might typically see weakness in hip adduction and knee extension. Sensory loss would follow the L3 dermatome, usually along the anteromedial thigh. The patellar reflex, the knee jerk, might be diminished or absent.
And L4.
An L4 radiculopathy often presents with weakness in ankle dorsiflexion. Clinically, you test this by asking the patient to walk on their heels.
Difficulty lifting the front of the foot.
Exactly. There's frequently a decreased or absent patellar reflex here too. Sensory changes typically follow the L4 dermatome, across the lateral thigh, crossing the knee, and down to the medial ankle, the medial malleolus, and the medial side of the foot.
What about L5? That's very common, isn't it?
L5 radiculopathy is perhaps the most common. It's characteristically associated with weakness of the extensor hallucis longus, the EHL muscle.
The one that lifts the big toe.
Precisely. Weakness in lifting the big toe upwards against resistance is a key sign. It also often impacts ankle dorsiflexion, making heel walking difficult or impossible. Patients might also show weakness in ankle inversion, turning the foot inwards, and hip abduction, moving the leg out to the side. The dermatomal pain typically runs along the anterolateral aspect of the leg and across the top, the dorsum of the foot.
And finally, S1.
For S1 radiculopathy, the primary motor deficit is ankle plantar flexion weakness.
Pushing down with the foot like going on tiptoes?
Exactly. The definitive test is having the patient perform single-leg tiptoe stands. There's almost always a decreased or absent Achilles tendon reflex. The dermatomal pain will be felt in the posterior calf and down the lateral aspect of the foot, often radiating into the little toe and the adjacent one.
That's a really clear breakdown for the lumbar spine. What about the neck, the cervical spine?
Moving up to the cervical spine, a herniated disc there can cause cervical radiculopathy. Symptoms of nerve compression in the neck can include a dull ache or a sharp shooting pain, either in the neck itself or sometimes between the shoulder blades.
Radiating down the arm.
Frequently, yes. Pain radiating down the arm, sometimes all the way to the hand or specific fingers. This may be accompanied by numbness, tingling, or weakness in the shoulder, arm, or hand. The pain in the cervical region often increases with certain neck positions or movements, as these can further compress the irritated nerve root.
Are there other general symptoms we should look for?
Yes. Regardless of the spinal region, look for loss of deep tendon reflexes patellar or Achilles in the lower limb, biceps or triceps in the upper limb. Also, significant persistent muscle spasms in the affected areas are common. These spasms are often the body's protective mechanism attempting to immobilize the painful segment. Now, a crucial alert, one that cannot be overstressed: cauda equina syndrome, CES.
The emergency situation.
Absolutely. It's extremely rare, maybe 1 to 10% of surgical cases, but exceptionally severe. It demands immediate medical attention, a true neurosurgical or orthopedic emergency.
What are the key symptoms again?
Hallmark symptoms include bilateral leg pain and weakness. That's a key differentiator from the typically unilateral pain of standard sciatica. Critically, it presents with saddle anesthesia.
Loss of feeling in the perineal area.
Yes, inner thighs, buttocks, genital rectal area feeling like you're sitting on a saddle without sensation. Most urgently, and defining the emergency, is any new onset loss of bladder or bowel control, typically urinary retention, difficulty starting urination, or overflow incontinence.
And finding these means.
These findings are definitive indicators of severe, rapidly progressive spinal nerve root compression at the very end of the spinal cord. Early diagnosis and intervention are paramount to prevent permanent neurological deficits, chronic pain, motor weakness, irreversible bowel and bladder dysfunction. Delaying even hours can have lifelong consequences.
That comprehensive symptom breakdown, especially highlighting the nuanced differences in radiculopathy and the critical nature of CES, underscores the importance of astute clinical observation. So, with a patient presenting with these kinds of symptoms, how do medical professionals effectively confirm a diagnosis and pinpoint the precise issue, especially given the challenges of differentiating a disc herniation from other spinal pathologies?
That's precisely where the art and science of clinical practice converge. The diagnostic pathway always begins with a thorough, meticulous medical history and a comprehensive physical examination.
Starting with the history.
Yes. The clinician will meticulously inquire about the quality, onset, duration, and impact of the pain on the patient's daily life work, sleep, personal care. We'll ask about any potential mechanism of injury, any current or past treatments, and their effectiveness, previous similar episodes. Crucially, during history taking, we're actively screening for those critical red flag symptoms.
The ones that might suggest something other than a simple disc herniation?
Exactly. Things like unexplained fever, night sweats, unintentional weight loss, a history of malignancy, any signs of systemic infection, or extreme escalating pain that is unremitting, unresponsive to usual analgesia, especially pain worse at night or at rest. These could point towards tumors, infections, or inflammatory conditions needing different management.
Then the physical examination.
The physical examination involves several key components, each designed to objectively confirm and localize the nerve root involvement. A detailed neurological examination is paramount.
Testing strength, sensation, reflexes.
Precisely. We determine any objective muscle weakness or loss of sensation to help localize the affected nerve root. This includes checking strength across key myotomes, asking the patient to walk on heels and toes, test dorsiflexion and plantar flexion strength, respectively. We test hip abduction, new extension. We meticulously assess light touch sensation across the dermatomal distributions, mapping any areas of numbness or altered sensation. And we test deep tendon reflexes at the knee and ankle, noting if they're diminished or absent. One of the most important and clinically predictive physical findings, especially for identifying potential surgical candidates and confirming radiculopathy, is the straight leg raise test.
The SLR or Lesiegs sign.
Yes, it's performed with the patient lying supine. The examiner carefully lifts the affected leg straight, keeping the knee fully extended. A positive test is the reproduction of the patient's characteristic radicular pain and paresthesia radiating down the leg, usually below the knee, typically occurring between 30 and 70 degrees of hip flexion.
That's a strong indicator for L4, L5, S1 problems.
It is. A positive test is a strong clinical indication of a herniated disc compressing those roots. Its specificity is quite high when positive.
Are there variations?
Yes, the contralateral SLR or cross straight leg test. This is even more specific, though less sensitive. If lifting the asymptomatic leg reproduces pain in the symptomatic leg, it strongly suggests a more central disc herniation causing significant nerve root irritation.
What about higher lumbar levels?
For higher lumbar disc herniations affecting L2, L3, or L4 roots, the femoral nerve stretch test, or Wassermann sign, is valuable. This is done prone, flexing the knee and extending the hip. Pain reproduction in the anterior thigh indicates tension on the L2 or L3 nerve roots.
And observing how the patient walks.
Gait analysis is critical. Observing for subtle signs like a Trendelenburg gait, where the hip drops on the non-weight-bearing side, can indicate gluteus medius weakness, often associated with L5 radiculopathy. It points to a specific motor deficit. It's important to reinforce that a clinical diagnosis of lumbar disc herniation with radiculopathy can often be made reliably and confidently without immediate imaging.
Based purely on clinical findings.
Yes, especially when the straight leg raise test is positive and the Hancock rule criteria are met. This rule requires at least 3 out of 4 specific findings. Clear dermatomal pain distribution, an associated sensory deficit matching that dermatome, a relevant reflex abnormality, and objective motor weakness in the corresponding myotome. This combination provides a robust clinical picture that guides initial management effectively.
That detailed approach to clinical examination, especially the nuances of the SLR test, offers incredible clarity. But as you highlighted earlier, there's a delicate balance. What's fascinating here is the interplay between this meticulous clinical presentation and what we can actually see inside the body with imaging. Which imaging modalities are truly indispensable for confirming these diagnoses, particularly when symptoms persist or red flags emerge? And perhaps more importantly, when should we not reach for imaging straight away?
That's a crucial distinction, absolutely. It speaks directly to effective resource utilization and sensible patient management. While the clinical exam is paramount, imaging provides objective anatomical confirmation and helps rule out other pathologies. However, and it's vital for our audience, for you, to understand this, imaging studies are generally not recommended during the initial 6 to 12 weeks for acute low back pain or radiculopathy.
Not unless there are red flags.
Exactly. We only deviate from this conservative stance if specific red flag symptoms are present. Cauda syndrome, progressive neurological deficits, signs suggesting infection or a tumor.
Why the wait?
The rationale is multifaceted. Firstly, disc herniations are surprisingly prevalent even in asymptomatic individuals. An early MRI might reveal a finding that isn't actually the source of the pain.
Leading to unnecessary anxiety or interventions.
Potentially, yes. Moreover, the vast majority of these acute presentations will resolve with conservative management anyway. So early imaging often doesn't actually alter the initial treatment plan. It doesn't change what we do in those first few weeks. When imaging is indicated, however, we have a range of tools.
Starting with x-rays.
X-rays are primarily used as a first-line screening tool. They excel at evaluating the overall alignment of the spine, looking for instability, and identifying other potential bony causes of pain fractures, significant spondylolisthesis, slippage, tumors, infections like osteomyelitis, or significant degenerative changes like narrowed spaces or bone spurs.
But they don't show the disc itself?
Critically, no. X-rays cannot directly visualize a disc herniation because they're not designed for soft tissue. However, flexion extension dynamic views can be useful to assess for spinal instability, which might influence treatment decisions.
What about CT scans?
Computed tomography, CT, offers detailed cross-sectional images and is particularly sensitive for bony structures. It's excellent for identifying calcified discs, subtle fractures, or bone destruction from tumors or infections. Traditionally, it was less effective for visualizing nerve roots compared to MRI.
But there's CT myelography.
Yes, a CT myelogram involves injecting contrast material into the cerebrospinal fluid. It can then indirectly visualize nerve compression by showing indentations in the contrast column where something is pressing. This is often used when MRI is contraindicated, perhaps due to a pacemaker or certain metallic implants. And modern multi-detector CT scanners have significantly improved diagnostic accuracy even without myelography.
Which brings us to MRI.
Magnetic resonance imaging. MRI is unequivocally considered the gold standard for diagnosing lumbar disc herniation and virtually all soft tissue pathologies of the spine.
Why is it so good?
Its superiority lies in its unparalleled ability to provide clear, high-resolution, multiplanar 3D images of soft tissues, the discs, the spinal cord, the nerve roots. It's highly sensitive and specific for detecting herniations, degeneration, spinal stenosis, and other intraspinal pathologies.
And useful for surgical planning.
Invaluable for preoperative planning. It offers surgeons a precise roadmap of the anatomy and the compression. In revision surgeries, using gadolinium contrast can be helpful. Scar tissue typically enhances with contrast, whereas a recurrent herniated disc, being avascular, generally does not.
When is an early MRI indicated then?
An MRI is definitely indicated relatively early, usually within 8 weeks, if the patient presents with significant or progressive neurological motor deficits, intractable pain, unresponsive to initial conservative measures, or, of course, the emergent cauda equina syndrome.
What about nerve conduction studies, EMG and NCS?
Electromyogram and nerve conduction studies. These are infrequently ordered as initial diagnostic tests for acute herniation. However, they can be invaluable in specific scenarios. They measure electrical impulses along nerves and within muscles.
Providing functional information.
Exactly. They give objective physiological evidence of ongoing nerve damage, signs of healing from a past injury, or can help identify other sites of nerve compression, like peripheral neuropathies, that might mimic radiculopathy. They're particularly useful when MRI findings are equivocal, but clinical suspicion remains high, or to differentiate from other neuromuscular conditions. They confirm the functional impact of the anatomical compression, seen on imaging.
That's a masterful breakdown of the diagnostic tools and, crucially, when to deploy them. It truly underscores that a careful clinical eye should always precede the push for advanced imaging. So once we have that clear picture of the herniation, or indeed decided that a clear picture isn't immediately necessary, what are the primary treatment pathways? Let's start with the non-surgical approaches that, as you've highlighted, the vast majority of patients ultimately benefit from.
Indeed. Having a precise diagnosis, or at least a strong clinical suspicion, is the first critical step. And it is absolutely paramount to reiterate for our audience, for you, that the vast majority of symptomatic lumbar disc herniations are, by their very nature, self-limiting.
They get better on their own, mostly.
Mostly, yes. Approximately 85 to 90% of cases will resolve within 6 to 12 weeks with conservative, non-surgical treatment alone. Patients without radiculopathy often improve even faster.
How does that happen? Does the disc just pop back in?
Not usually pop back in, but the body has remarkable intrinsic healing processes. Mechanisms like macrophage phagocytosis, where immune cells clear up the extruded material, and enzymatic degradation can lead to the gradual reabsorption and shrinking of the herniated fragment over time. This reduces its mass effect and the chemical irritation on the nerve root. So let's detail the initial conservative approaches, often used in a stepped care manner.
Okay, first steps.
Activity modification and rest. The immediate advice is to limit painful activities for a very short duration, maybe 1 to 2 days initially, allowing acute inflammation to subside. However, and this is a key message for patients, we strongly discourage prolonged bed rest.
Why is that? It seems intuitive to rest.
Extensive evidence now shows prolonged inactivity can actually delay recovery, lead to muscle deconditioning, and even worsen outcomes. Instead, gentle activity, like walking as tolerated, is actively encouraged from the outset.
So keep moving gently.
Yes. Patients should then gradually and controlledly resume normal activities, with specific emphasis on avoiding movements known to exacerbate pain, bending forward, twisting, heavy lifting. Education on proper spinal mechanics is crucial here.
What about medications?
Pharmacological interventions aim to manage pain and inflammation. Non-steroidal anti-inflammatory drugs, NSAIDs like ibuprofen or naproxen, are typically the first-line agents for mild to moderate pain and inflammation. Use them judiciously, considering potential side effects.
Muscle relaxants.
They may be considered, particularly if there are significant muscle spasms, though their effectiveness beyond placebo is often modest, and they can cause drowsiness.
Oral steroids.
A short course of oral corticosteroids, a taper, can offer modest but often clinically significant improvements in function by powerfully reducing inflammation around the nerve root. Their direct impact on pain relief might be less profound than the functional benefit for some.
And narcotics. Opioids.
These are generally avoided for chronic or subacute low back and radicular pain. The risks of dependence are significant. They can complicate post-operative pain control if surgery becomes necessary, and there's growing evidence associating them with worse surgical outcomes. If used at all, it should be for a very short duration, maybe 2 to 3 days, purely for severe acute breakthrough pain under strict supervision.
Physical therapy seems key.
Physiotherapy, PT, is the cornerstone of conservative management. It's usually initiated around 3 weeks after symptom onset, after that initial period of relative rest. A tailored program is vital, based on a thorough evaluation.
What does that typically involve?
It may include strengthening exercises, focusing on the core muscles lower back, and abdominals to improve spinal stability. Flexibility and stretching exercises to improve range of motion and reduce muscle tension. Modalities like pelvic traction, gentle massage, ice and heat therapy, ultrasound, electrical muscle stimulation can provide symptomatic relief.
And education.
Education on proper body mechanics is indispensable, teaching patients how to move, lift, sit in ways that minimize spinal stress. Often, methods like the McKenzie method are used.
McKenzie, what's that?
It's mechanical diagnosis and therapy. It involves identifying movements or positions that centralize the patient's pain, move it from the leg back towards the spine. Then, prescribing repeated exercises in that directional preference. For lumbar disc herniations, this is most commonly extension exercises, like gentle backward bending. It can be profoundly beneficial.
What if these measures aren't enough? What about injections?
Epidural steroid injections, ESIs. These are typically considered second line if other conservative measures, PT, medications haven't provided adequate relief, usually after 6 weeks to 3 months.
How are they done?
They're performed under X-ray, fluoroscopic guidance, to ensure precise delivery of a potent corticosteroid directly to the affected nerve roots and the epidural space.
And the goal is?
The goal is to provide significant, albeit often short-term, pain relief usually lasting 2 to 4 weeks by powerfully reducing inflammation around the compressed nerve. They are particularly effective for extruded discs, where there's a clear inflammatory component.
But they don't fix the disc.
No, it's crucial to counsel patients that ESIs don't heal the herniated disc itself. They improve function, reduce pain, and can provide a window of opportunity for physical therapy to be more effective while the body continues its natural reabsorption process. A practical point. There's a slight increased risk of infection noted if injections are given within 3 months prior to subsequent surgery, which needs consideration.
That's an exhaustive and incredibly practical guide to conservative management, highlighting both the options and the need for patience. So what happens when these non-surgical avenues, despite a diligent approach, simply don't provide the necessary relief? When does surgical intervention, often seen as the last resort, truly become a consideration?
That's a critical transition point. Surgical intervention is, by design, reserved for a relatively small percentage of patients, typically only about 5% of those with symptomatic disc herniations.
So 95% avoid surgery.
Broadly, yes. Surgery is for individuals who meet specific criteria, usually after a significant period of non-surgical treatment, often 6 to 12 weeks, has failed to alleviate their debilitating symptoms. However, remember those red flags, Cauda equina syndrome, rapidly progressive neurological deficits? Those necessitate urgent surgical evaluation, bypassing the usual conservative trial period.
What are the main reasons for elective surgery then?
The most common indication is persistent, disabling radicular pain. The pain radiating down the limb must be severe, unremitting, significantly limiting normal activities or quality of life, lasting more than 6 weeks, and demonstrably failing comprehensive conservative treatments, including injections. The key is disabling pain.
What else?
Progressive neurological deficits. If the patient shows worsening leg or arm weakness or increasing numbness over time, surgical decompression is often warranted to prevent permanent nerve damage.
And the emergency, CES?
Loss of normal bowel and bladder functions, Cauda equina syndrome, requires immediate surgery, ideally within 24 to 48 hours. Also, severe functional impairment patients who simply cannot stand or walk properly due to symptoms, despite conservative efforts. And generally, the patient needs to be in reasonably good overall health to tolerate surgery and recovery.
What are the common surgical procedures?
Microdiscectomy is by far the most common and highly successful procedure for a single herniated disc causing radiculopathy. It's the gold standard.
What does it involve?
It's often performed through a small incision, less than an inch, using a surgical microscope or magnification. This allows the surgeon to precisely remove only the herniated part of the disc and any fragments compressing the nerve root, preserving the healthy portions.
And the outcomes?
Generally very good. Studies consistently show significant improvement in leg pain, often immediate. Leg pain improves more reliably than associated low back pain. Most patients resume normal activities after recovery. Neurologically, pain relief comes first, then strength gradually improves, then sensation recovery is slowest.
What about endoscopic surgery?
Endoscopic discectomy is a newer, increasingly popular, minimally invasive option. It uses an endoscope with a camera through even smaller incisions, sometimes just millimeters.
Potential benefits?
Reduced muscle disruption, smaller incisions, less scarring, potentially shorter recovery times. Early results are promising, comparing favorably to microdiscectomy. But long-term comparative data is still evolving. It's a rapidly advancing field.
Are there other procedures?
Lumbar laminotomy or laminectomy are older procedures where part or all of the lamina, the bony arch, is removed to access the disc. Sometimes needed for large or calcified herniations or associated stenosis. Spinal fusion might be added if there's instability, but that adds recovery time and limits motion, so it's reserved.
And artificial discs?
Artificial disc replacement, ADR, is more an alternative to fusion for degenerative disc disease, aiming to preserve motion. For isolated herniations without significant degeneration, it's a niche option with strict criteria, single level, certain lumbar levels, no infection, osteoporosis, significant facet arthritis, or instability. It generally doesn't offer a significant advantage over microdiscectomy for a simple herniation.
Does the timing of surgery matter for elective cases?
Yes, timing is important. While CES needs immediate surgery for elective radiculopathy, studies like the SPORT trial suggest surgical outcomes are generally more beneficial if addressed within 9 to 12 months from symptom onset.
Why is that?
Patients who delay surgery too long beyond this window may experience less overall improvement in pain and function compared to those operated on earlier. There seemed to be a sweet spot before chronic nerve irritation leads to potentially irreversible changes.
That detailed overview of surgical options and timing is invaluable. This naturally raises an important consideration. What are the potential risks associated with these surgeries? And crucially, how do patients navigate the post-operative journey effectively?
An essential point for patient counseling. All surgery carries inherent risks. While most microdiscectomies are successful with minimal complications, patients must be fully informed. Minor risks include bleeding, infection at the site, rare with prophylactic antibiotics, and reactions to anesthesia.
What are the specific risks for spinal surgery?
Direct nerve injury is rare, but possible, potentially leading to persistent weakness, numbness, or increased pain. Meticulous technique and sometimes nerve monitoring help minimize this. Dural tear in the sac covering the nerves is relatively common, maybe 1–7%. It needs careful repair and possibly bed rest, but it usually doesn't affect long-term outcomes if managed well.
Other risks.
Epidural hematoma bleeding causing nerve compression post-op might require reoperation. Recurrent disc herniation is notable, occurring in 5–25% lifetime risk, at the same or different level, regardless of initial treatment. Vascular catastrophe injury to major vessels is exceedingly rare but devastating. Long-term, some patients may have persistent low back pain or epidural fibrosis, which is scar tissue around nerves, sometimes causing recurrent symptoms.
How critical is rehabilitation after surgery?
Absolutely crucial for optimizing outcomes, accelerating recovery, and minimizing recurrence risk. Physical therapy is almost always recommended.
What does post-op rehab look like?
The initial phase often involves a simple walking program, starting short and frequent, gradually increasing. This aids mobilization and circulation. This is coupled with specific, guided exercises to gently restore strength and flexibility.
Are there restrictions?
Yes, to reduce reherniation risk while the annulus heals, patients are typically advised to avoid bending at the waist, heavy lifting, often restricted to 5–10 kilograms initially, and twisting for the first few weeks or months, depending on the protocol.
What should patients expect during recovery?
Some discomfort and muscle soreness are expected with gradual return to activity and PT. However, any new or escalating radicular pain is a warning signal to slow down and consult the team. Remember the typical progression. Leg pain improves first, often dramatically, then strength returns gradually, and sensation is slowest to recover, potentially taking months. Patience and consistent adherence to rehab are key.
That's incredibly thorough and pragmatic advice. Let's move into our lightning round for some quick, high-impact takeaways. First, in one sentence, what's your top advice for preventing herniated disc recurrence?
Maintaining a strong, stable core musculature and consistently practicing proper body mechanics for all lifting and daily activities is paramount for long-term spinal health and preventing recurrence.
Beyond the clinical interventions, what's a surprising factor you've seen profoundly influence patient outcomes for the better?
Without a doubt, it's the patient's active engagement and their psychological resilience. Patient education, active participation in rehab, coupled with a positive, proactive mindset, fundamentally empowers recovery and improves adherence. It's the human element.
For our audience of medical professionals, what emerging trend or area of research in disc health do you find most exciting right now?
The ongoing research into biological therapies for disc degeneration, focusing on things like cellular senescence targeting, or using growth factors and stem cells for repair, alongside the continuous refinement of minimally invasive endoscopic surgical techniques, offers incredibly promising avenues for faster, less invasive recoveries and improved patient experiences.
And finally, for those in our audience wanting an even deeper dive, are there specific resources or tools you'd highly recommend?
For comprehensive overviews and guidelines, materials from reputable bodies like the American Academy of Orthopedic Surgeons, AAOS OrthoInfo, or the American Association of Neurological Surgeons, AANS, are excellent. For more in-depth clinical data and practical summaries, OrthoBullets provides succinct reviews, and StatPearls offers detailed, regularly updated articles on pathophysiology and management.
Professor, that has been an extraordinary deep dive. Your expertise has illuminated so many critical facets of lumbar disc herniation. It's been an absolute masterclass. Let's recap some critical insights for our listeners today.
It's been a true pleasure discussing these crucial insights with you.
First, a refreshed understanding of the disc itself. A complex vascular structure. The nucleus provides compressibility, the annulus tensile strength. The key insight: age-related degenerative changes are often the primary drivers, predisposing the disc to injury.
That's fundamental.
Second, diagnosis isn't always straightforward, and patience is a virtue. While MRI is gold standard for imaging, meticulous clinical history and examination, including tests like the SLR, are paramount. Clinical correlation should always lead.
Avoid treating the scan alone.
Exactly. Third, conservative care truly reigns supreme. Remember, 85 to 90% resolve spontaneously with non-surgical treatments, activity modification, targeted PT, judicious medication use. The takeaway is patience and adherence to tailored rehab, trusting the body's healing capacity.
The natural history is often favorable.
Fourth, surgery is a considered and effective option for specific cases. For those with persistent, disabling radicular pain or critical neurological deficits failing conservative management, procedures like microdiscectomy offer effective, often faster relief. Insight, precise patient selection, and timely intervention are crucial.
Right intervention, right patient, right time.
And finally, prevention and long-term vigilance are key. Ergonomics, healthy weight, core strengthening, proper body mechanics. These aren't just recommendations. They are vital, lifelong strategies to protect spinal health and reduce reherniation risk. Patient empowerment makes a difference here.
Absolutely crucial for long-term success.
Professor, thank you again for sharing such invaluable expertise and making a complex topic so accessible and actionable. This has truly been an enlightening deep dive.
It's been a genuine pleasure to discuss these insights and share them with your astute audience.
If you found this discussion as enlightening and clinically relevant as we did, please take a moment to rate and share this deep dive with your colleagues and network, particularly on platforms like LinkedIn and X. Your feedback helps us continue to bring you these essential conversations. So what nuanced clinical scenario will you approach differently after this deep dive? Join us next time on the Deep Dive, where we'll continue to unpack complex subjects and provide you with the knowledge you need to stay well-informed and at the forefront of your practice.